Did y'all know that pandas aren't just bears? It's actually a disease too.
That's the joke.
This is where I get frustrated.
Don't even open that can of worms.
Like horrifying.
Horrifying. Not allowed to cry or have emotions in your house.
Like, do you really need to know what Zemoglobin 8 is? Or
Oh, Jessica.
everyone has a favorite. Everyone does.
Okay, guys, today we are going to talk about two diseases that are very similar, PANS and PANDAS. And we have with us Dr. Benton Marino, who's a pediatrician in our community, and he sees a ton of kids that have PANS and PANDAS. And so we're going to pick his brain about it today.
Yeah, thanks for being here.
Thank you for having me.
Yeah.
Hopefully I can help shed a little light on it.
Yeah.
More light than no light.
Yeah.
Bada bing. Go ahead.
Okay, so this is very near and dear to my heart because one of my kids was diagnosed with PANS in August of last year.
What is PANS?
So PANS is Pediatric Acute-onset Neuropsychiatric Syndrome, okay? And then PANDAS is Pediatric Autoimmune Neuropsychiatric Disorders associated with Streptococcal Infections. Okay, so PANDAS it's basically like the same symptoms, but PANDAS is due to a strep infection. PANS is due to something else. So it can be like viruses, toxin exposure, all kinds of things.
Okay.
So we went through a very long, hard journey with my son, starting when he was really little. He had aggression as a toddler, but he was a toddler. So I kind of,
write it off.
I didn't write it off. Like I was paying attention to it, but I was also like, lots of toddlers are aggressive. He might grow out of this. It wasn't like super concerning when he was 2. And then when he was 3, I started to notice like he had like weird sensory things. Like he would, this is kind of weird, but every time he had to poop, he would get like crazy aggressive, like Hulk.
Oh,
He would like
weird.
Hulk out. Like it was like he like went psycho, and then he would poop and he'd be totally fine. And this was when he was like little bitty, like 2.5, 3.
Yeah.
And then loud noises. Like he was really loud himself.
Yeah.
Like he would like bang and be super loud. But then other loud noises, he had this like extreme startle response. Like it was like really extreme, and he would like freak out. And he'd, we never like hit him or anything. He'd never been traumatized. So it was bizarre. Like he was acting like a traumatized little animal. And so I took him to, like, I kind of was going about this in the way that I knew from my training. I was like, oh, like he's got a sensory processing problem. So I took him to OT, and I remember them evaluating them, and they're like, nope, he doesn't have a sensory issue. And I was like so desperate. I was just like, no, please treat him. Like, please help him. Like, I don't, like, they're like, you're not going to meet, insurance isn't going to pay. I was like, I don't
Doesn't
care.
matter.
Like, I'll pay. Like, something's wrong. So I kind of had to like convince them to treat him. And then after like 6 or 8 months, they're like, there's nothing else we can do. And they like discharge him. And I was like, fuck. Because by that point, like his symptoms were like progressing. They were getting worse. The aggression was getting worse. And so then it was like, group play therapy, individual play therapy. We were doing like all the things, and nobody was like, the alarm bells had not really been sounding until he was in like pre-K 4. And his aggression got really, really bad and like really scary at school. Like he was seriously hurting kids.
Yeah.
And we were doing everything. Like there was like nothing else I could try. We tried putting him on medicine. We put him on stimulants. We put him on non-stimulants. We put him on SSRIs. Like we tried everything. We changed his diet, and it wasn't getting better. And this, I think what like hit me was the school had, we had so many meetings with the school, but at one meeting, they were like, we think he's depressed. And I was like, my 4-year-old is depressed. Like, what are you talking about? Like, 4-year-olds can't be depressed. And they're like, his face is depressed. Something is wrong. And his level of like irritability and anger was like out of control.
Yeah.
So fortunately, I knew a pediatrician. I wish I'd known about you at the time. I didn't know you existed until more recently.
I didn't
But
exist.
so I knew a pediatrician who was doing more like integrative workups, and she just happened to already be their pediatrician. But she was like breaking off from her current practice and doing like more integrative type.
Hernandez.
Yeah, Hernandez, Lauren Hernandez, who's been on our show.
Yeah.
And but I didn't know she was doing this integrative stuff until a friend of mine told me. And so I like approached Lauren at a kid's basketball game, and I was like, I'm so desperate, please help me. And so she, you know, we started slow. She like did a gut workup, and she did like food sensitivity, and like we kind of were getting like little bits of information
too,
along
right?
the way. Well, that was later.
Oh, okay.
So the gut was like horribly inflamed.
Yeah.
I was like, okay. And then we do food sensitivity, and it's like, okay, he's extremely reactive to eggs. And we're like, what the fuck? Like, you know, he eats eggs every day. We're like, okay, we'll cut that out. And then finally, I knew that they were doing this like brain mapping thing, but he was technically too young. And I was just like, just please do it.
Yeah.
Just please do it. Like, I'm so desperate at this point. So we did it, and he had like massive inflammation in his brain. And so then she was like, let's just work him up for PANDAS. Like the story kind of didn't fit because this had started when he was teeny tiny, and that's not usually how it starts. But turned out, you know, he had like wildly elevated antibodies for mycoplasma and for cytomegalovirus, which are like two of the main causes of PANDAS.
But what
two
is that?
viruses. They're
Like
viruses.
layman's terms.
So mycoplasma is like one of the most common causes of, or is the cause of walking pneumonia.
Okay.
And once we found that out, we thought back and we were like, oh my God, he did have walking pneumonia. He had pneumonia during COVID. It was not COVID. He was negative for COVID. He had double pneummonia all over. And it was COVID, and I was pregnant with my third kid. And so we kind of forgot about it.
Yeah.
And then we did further workup with a integrative pediatrician in Alabama who like specializes in PANS and PANDAS. And he ran like this huge panel of autoantibodies. And I mean, everything was like off the charts for him.
What's an autoantibody?
So it's like these antibodies that are elevated when you have an autoimmune disease.
Oh, okay.
Okay.
So he did a test to screen for that.
Yes.
Okay,
And it was like 6 or 7 of them, and they were all like off the charts. And that doesn't just like happen.
Yeah.
You don't just have that as a 6-year-old, you know,
Yeah.
or he was 5 at the time. So that, and then the history like confirmed the diagnosis. And since starting treatment, it has not been like perfect, but he has literally done a 180 from where he was last year.
It's great.
Yeah.
What's the treatment?
He's done a lot. He's done antivirals, antibiotics, anti-inflammatories. We ended up he had relapsed a few times between those, and so we found out he has
What do you
mold
mean
toxicity.
relapse?
So like he would do a trial, and his symptoms would be like gone. Like he was not aggressive, he was like happy, he wasn't irritable, and then like 3 weeks later, all those symptoms would come back.
Why?
So we found out. So the pediatrician who we saw in Alabama was like, okay, something is causing like an underlying persistent inflammation. We have to figure out what it's going on. So he was like, the most common thing would be mold toxicity. So we tested him. He was positive. And then he told me, I have an autoimmune disease. So he's like, you probably have it too. Because my symptoms started at the same time as my son's. So then we tested me, and I had the same mold.
Yeah.
So he did a mold detox. And he has not had a relapse since then.
Oh, great.
Yeah.
That's awesome.
Great.
So anyway, that was a long-winded story
No.
to tell us
but-
how we got here.
Yeah. PANS and PANDAS. I mean, honestly, what is it? Like you said all those words and what causes it, I guess. But like what is it?
Yeah, I think the best way to describe it is that it's a misdirected immune response that results in newly or abrupt onset of OCD and other related issues, and some of those are neuropsychiatric issues. And there's a whole list of them. So to meet the definition, you have to have an abrupt onset. So that has to be part of it.
Define abrupt onset?
Pretty much overnight.
Oh, what? Like if I woke up tomorrow, not me, but like
If a child wakes up, one day and he's just a totally different child, and the symptoms came on overnight. So it's usually not a long-standing issue. But the problem comes in, I'll get to that later, is that when you have young kids and you don't know, okay, this is part of, they have a bad day, or they didn't sleep well, or they're not feeling well, and they've just been a little off, and then you just, write it off to a terrible 2, or and then you just kind of let it go, and or think maybe it's something else, and it just kind of keeps going for a little bit.
And you have at 2, you don't have any baseline for who they are, right?
Exactly.
Which was my problem.
So I think that's a big issue where it's underdiagnosed. in that area. So they have the acute onset of the neuropsychiatric symptoms, and OCD has to be one of them. I'm going to ask you a question about that in just a second. But the other ones have to be, or two of the following: anxiety, which might be separation anxiety, emotional lability and/or depression, irritability, aggression, severe oppositional behaviors, behavioral regressions, sudden deterioration, sometimes in school performance, sometimes it's other types of performance, motor or sensory abnormalities. Sometimes those might include tics or movement disorders, which I have a patient that presented that way with a movement disorder. And then somatic signs, which I see a lot of. In fact, this is probably the most frequent way that they present to me is urinary frequency and urinary urgency.
Oh, interesting.
And then another big one is sleep disturbances. So those
you only have to have two of that laundry
of those,
list?
and they have to come on acutely, and it also has to be in addition to some sort of OCD or eating restrictive disorder that kind of comes on overnight.
So one kid, next day, I am displaying symptomology that is similar, whatever, to OCD, and I have to check two of those out of what, 20?
There's about 7, but they're all expanded.
So,
Okay.
They're all, they're pretty encompassing. They're pretty general.
Yeah.
Terms
That's what I'm saying. Yeah.
Like anxiety.
Like what?
Anxiety in a 3-year-old, and you can go into this too, is going to present different than anxiety in a 10-year-old.
Yeah.
So,
Right.
So that it varies, from child to child how they present with those types of symptoms. So, and I think that's why, again, the different age groups, and especially the younger kids, it gets missed, that abrupt onset that occurs. And I have cases where, it sounds just like you said it, the next day they're a different child. But then the kids that are between, 3 and 5 or in that age group, it's difficult to make the diagnosis, because a lot of it gets blamed on normal behavior or a bad day or, something like that. Or they're just a lot of times I'll get they're in a funk, or it's just a phase. That's what it is.
Yeah, everything's always a phase.
Yeah.
So,
In every stage of human life, I feel like. Everybody's, it's a phase.
and then the difference, I guess, between PANS and PANDAS is basically, and I think you kind of said it earlier, is that PANDAS means it's caused by strep or preceded by a Streptococcus infection, and then PANS, it could be preceded by other infectious triggers or environmental factors too, like you were talking about, like mold.
Yeah.
But there's other things that could.
But same symptomology for both?
Correct.
Yeah.
What's the OCD thing?
So, I can tell you, my son, and these were things that, I had not put together until I went to see the integrative pediatrician in Alabama, and he was asking me questions, and I was like, holy shit. He was saying, he had this compulsion to say, this is so terrible. He had this compulsion to say, I'm going to kill myself. And he would just be like, I'm going to kill myself. I'm going to kill myself. It was so weird. We had a play date with someone, and he just was jumping on the couch, and he was like, I'm going to kill myself. And as soon as he started the first treatment, it went away. I've never heard it since.
That's so interesting.
So bizarre. That, and then
Well, how did you know it was a compulsion then?
I didn't at the time.
So
when he was asking me questions, and he was saying, asking me examples, and he was like, is there anything that he repeatedly says? And I was like, oh my God, he does this weird thing where he says, I'm going to kill myself, and I don't know where it comes from. And he was like, okay. And he just took note of it. But then he also, he still is kind of like this, but he is very compulsive about certain things, about seams in his socks, and
what does he do? Mess?
He will, if it's not perfectly on the edge of his toes, he freaks the fuck out.
Yeah.
He's freaking out. For a while he was really compulsive about food. And he had the food restriction thing where he had stopped eating a lot of things, and then he had gotten to the point where he was barely eating at dinner at all, which has gone away. Now he eats like a horse. So there was a lot of little things that, it's when they're that age and you have other kids and you're working and you're just not paying attention.
You're so distracted. It's hard.
You're not paying attention until someone sits you down and asks the questions, and then you're like, damn. And the separation anxiety was actually,
that was a big, that's why
his was so bad. So my child can run into school, run into a birthday party, not look back, like run into a new situation, totally fine. He could not walk to the other side of the room without one of us. And it wasn't just like, oh, he's looking for attention. He would be crying and like trembling in fear. He literally couldn't walk to the other side of the room. Definitely couldn't go in another room by himself. It was bizarre.
Yeah, and that's not, that's one of the more common things too.
Yeah.
And I'll go back to that in just a second. But the OCD aspect of it, I think it gets missed and maybe I was, when I was practicing earlier before I knew much about this, maybe 5 years ago, I thought OCD was a kid that walks to the bathroom and washes their hands 15 times and has to step over the door and walk back and close and open the door 5 times and then they can leave the house. And I've, there are kids that present like that, but OCD, might be presenting in a different way. And when kids have, looping thought or, a thought that just continues in their head,
Like
for
ruminating.
example, correct.
Yeah.
They might be thinking, that they're really sick or they're going to die or something like that, or a fear that just, and they don't talk about it. They don't tell anybody about it.
Like those
It's hard to
intrusive
tease
thoughts.
that out unless you get
Yeah.
these specific questions, like when the doctor asks,
Yeah.
the questions about, does he say things over and over again?
Yeah.
So that's a broad, I think, group of symptoms too. So I think that gets missed. I think a lot of providers don't ask these questions, and a lot of parents brush off some of the things that are OCD because it's easy to pick up the 5-year-old that washes their hand 15 times, but it's not when they're having other symptoms like excessive worries and things like that. They're not expressing. So maybe you can talk more about some of the OCD symptoms that you've seen and some of the things that younger kids might present with.
Yeah, so like for my son, there was a lot about like okay, this is one thing. So he's a builder. He loves building, okay? And he gets super compulsive about his building. And so his was definitely more presenting as compulsive behaviors, but that's because he's really little. So if he's having obsessive thoughts, he probably can't verbalize them very well to us. But if people would like even touch what he was building, he would freak out because he was so afraid they were going to like mess it up. So he was like super compulsive.
Rigid.
Yeah, super
So really rigid.
Extremely rigid.
Inflexible thinking.
Completely inflexible. I'm trying to think of like other things that he did that he still kind of does a little bit, but they're like way, way better now. The food, clothes, building stuff, just like little things with like placement of objects. He would be like really compulsive about the way things were placed and like you couldn't touch it.
Why is it not like widely accepted?
I don't know the answer to that just yet, but I think I can go back to the history of it. So in the late 1800s, they started to describe, acute rheumatic fever and heart disease due to that, and that was well known. In the 1940s, acute rheumatic fever was more defined, and they gave the Jones criteria, which had to do with heart issues after a strep infection, and then some other findings that might be with your joints or your skin, rashes, and then a lot of those people also had something called Sydenham's chorea, which was involuntary movements after a strep infection due to brain inflammation. So that was taught to you in medical school, and that was taught to me in medical school. We had to memorize all these things, and you never saw a patient with with that. It's pretty uncommon, and people after antibiotics anyway, and because people were treated, with strep infections for with antibiotics, and now. I think when I was in medical school, I don't know if we even had if it was even mentioned PANS or PANDAS, and then throughout residency, maybe I heard about it a few times. I did my residency in Dallas, and then I worked in Texas Children's in Houston, and you would run into patients, and they would say, my kid has PANS or PANDAS, and they were there for something else, maybe an ear infection or pneumonia or something. And I would just, you would roll your eyes. You're like, I don't have time for this. I need to, we need to treat this. And then we need to move on to the next thing.
Yeah. Well, that's my question is like, why your eyes ain't rolling no more?
Well, I think my eyes were opened a little bit. So I used to work in the hospital setting as a hospitalist, and then in the pediatric emergency room for a few years. And due to many blessings, but I guess sleep deprivation and having 4 children, it was impossible to continue that lifestyle. So I moved into a community clinic or a private pediatric clinic, and you get to know the patients. And so like when you're in the emergency room or you're in the hospital setting, you don't know these people, and
Quick turnover.
you just want to make sure you're treating the problem that they're there for, and then send them home because you got to get on to the next patient. And now that you know these people and you see them over and over again, and you know how they are, and you become friends with the or closer to the families, and you have a mom that calls you. So about 5 years ago, I had a patient that was admitted to Children's with a acute onset of paranoia and a movement disorder, and kind of came from nowhere. She was a little bit paranoid. They noticed when they went out of town one weekend, and then they came back, and she was, really severe and developed the movement disorder, or involuntary movements. I don't want to call it movement disorder. So she ended up getting admitted to Children's Hospital. She had $1 million workup with like MRI, lumbar puncture. Everybody in the hospital saw her, and she got put on a couple different psychiatric medications, and, relatively sedated and sent home without a diagnosis. And the mom, luckily is, very smart and well-educated in the field of education. And she, luckily did some research and some digging. And she's like, I think this is PANDAS. And I was like, okay. And so I saw her in the clinic, I think after she was discharged. And then I read a little bit about it, and I was like, I think this is PANDAS. It just didn't make sense for other things. And so one of the things that I think helps make the diagnosis, in her case, and a lot of kids' cases, is that, so she ended up having mycoplasma titers that were high. And that was really the only thing out of all of her, lab work that was out of the ordinary. So we treated,
what that is again, I forgot.
So it's a bacteria that causes different infections. Walking pneumonia, is one of them that's commonly, gets blamed for, but it causes other issues too. So when she was treated with antibiotics for a bit, she ended up getting better.
All right.
So, she was still on a couple different psychiatric medications, but it was a pretty quick recovery that like their child was back.
Yeah.
And then that's part of the diagnosis. So, if they have this, fairly quick turnaround where the child kind of comes back and so those symptoms go away with treatment, I think that helps solidify the diagnosis. So that was very drastic. I mean, the stories I would hear from, they would have to like lock her room, and they would have to check on her very frequently that she wouldn't try to leave the house. And she couldn't sleep because she couldn't stop, moving her arms. So that's a drastic, I guess, case, and not all the cases are like that.
Like everybody gets strep. Like I had to get my tonsils out when I was little because I got strep so much, just like recurring strep. What? So now I'm probably a penis.
Maybe.
No.
You were.
It's pediatric, so no.
Maybe you were undiagnosed as a child.
But it's like, I guess you can, I love a clear-cut case where it's like, you have this symptom, like you check that box, and that box. But when you have a kid who looks like, oh, it's ADHD, or like how, there have to be like so many more kids running around with this, misdiagnosed as like autism, ADHD, right?
Yeah. Well, so it's estimated that there's about 1 in 200 kids have this. That was a few years ago. So I think I went sideways with my story there. But Sue Sweeto is a pediatrician that worked for I don't know if she's still there, but works for the National Institute of Mental Health. And her and some of her colleagues were studying about 20 years ago Sydenham's chorea. And one of the patients with Sydenham's chorea ended up testing positive for strep in that group. That's the movement disorder that comes on after strep. And they were treated and ended up getting better very quickly. So then they started to look at other symptoms associated with it. And her and a group of individuals from the National Institute of Mental Health, they found a host of other symptoms like we just described, and they sat down and over the course of a few years, they laid out the diagnosis criteria for PANDAS. And if you listen to her talk, I think it sounds like there's some regret with how they named it, and I think they wish they would have named it a little bit
bear.
differently. And the criteria, I think they probably wish they would have changed some of the criteria, too. So you may hear some providers talk about it now as basal ganglia and post-infectious basal ganglia encephalitis, which just sounds more encompassing and has a little less taboo, to it. So, what happens, and you asked the question about like, why doesn't everybody have this?
Yeah.
There is a bit of genetic susceptibility to
Okay.
it. So, if there's a family history of a lot of autoimmune diseases, you're more likely to have that. And then not everybody's immune system has a misdirected response to a strep infection or another infection. So, when you get strep, your antibodies are supposed to see it, attack it, and get rid of it. But sometimes they start attacking your own tissue. And in PANDAS, it attacks the basal ganglia, in the brain and causes that inflammation and then subsequently these symptoms.
But like, why? Like, if you're like, why? like,
why would it happen to my kid? Is that what you're
or
saying?
no, just like, why? Or do some people's? I'm not gonna say this.
So some people are just genetically predisposed to have an autoimmune response. Period. Right.
Okay. Right.
So like
Meaning-
so my family is genetically predisposed to have autoimmune diseases. So my mom has like 10. I have one. My grandmother had a few, so like my genetics, like my body is just predisposed to like inflammation and attacking itself. Yeah. Okay. And unfortunately, like my kid inherited that.
Oh, okay. So history of autoimmune.
Correct. And I think it's about
disorders
65% of kids with PANDAS
have
a family history.
Okay.
Or mom or dad or somebody has an autoimmune issue.
Are there any other genetic components like that put someone at higher risk?
Not that I'm aware of. I mean, it is more prevalent in boys, so it's a little more than 2.
I actually didn't know that.
Yeah, it's a little more than 2 to 1.
Ah,
why do you think?
I know that.
Why do I think? I don't know. Boys
Because
we're
they're
just weaker.
I was gonna say the opposite.
didn't know that.
Like the symptomology is bigger with boys. Like they're seen more because they're
Maybe.
more outward.
I mean, now that I think about it, every one of
I
my
haven't
patients
seen
that has it
anybody.
is a boy.
Yeah, same.
Yeah. I would say
Interesting.
it probably lines up in my practice. I probably have somewhere between 50 to 75
What?
patients with PANDAS, and it's about 2 to 1
Wow.
boys.
Yeah.
You have that many? How did they know? How did they know that? Do you have a test?
That's a long.
We don't have time.
It's a long response. No, we have time. I think that's important too.
Okay, well then go ahead.
Yeah. So for testing, there's a lot of things that you might want to do for a test or that help lead you in the right direction. But it's really it's a clinical diagnosis. So the diagnosis is made by history and physical, and I think part of the diagnosis is confirmed after treatment. So if they have a strong response to treatment and things go away, and then they get illness again, and it comes back, a lot of times that's the proof that you need. A lot of people go out and spend a lot of money on different tests, but you can have tests and they're all negative. Like the first girl I was talking about, aside from the mycoplasma test, which a lot of people may not have done, MRIs and lumbar punctures and
that doesn't help.
all that stuff was normal with her.
Oh.
Even her strep titers, which strep titers can be normal in anyone that has a strep infection. They just may not rise. And then some kids that have strep infections and don't have PANDAS will, likely get strep titers, or their antibodies to the strep proteins will rise, 4 to 6 weeks after an infection, and those kids don't necessarily have PANDAS. So you can have 100% of your labs can be normal, and you can have PANDAS. So it's a diagnosis that's made, in the clinic from history and physical, and then I think response to treatment also helps confirm it. I've been wrong about a couple of kids that I've suspected, that maybe, have had PANS or PANDAS, and maybe they just have ADHD or they just have anxiety, and I haven't been able to to prove it. So I'm not, I'm certainly still learning a lot about it, and it's a difficult thing to treat. It's a difficult thing to have a discussion with the parents about.
Why?
Why? Because I have 10 minutes to see a patient, usually. And then when they bring it up,
like who brings it up first?
the parents a lot of the time, not all the time, but the parents sometimes will bring it up in the clinic, and they'll say,
I read this thing.
yeah, I'll look at my computer and I'll see, this patient's here for strep throat. And I was like, okay, well, they're just coming, I'm going to get a swab, and then we're going to be on to the next patient 10 minutes later. And then the mom's like, I think he's been, he's been kicked out of school, or he's been super anxious, or he hasn't been sleeping. And I was looking at this thing called PANDAS. Do you think he has PANDAS? And I'm just like,
I don't know.
I got 3 other patients that I have to see.
Yeah.
So that's where I think it's difficult, because you've got just 10 minutes sometimes with them. And, in those cases, I've started to just say, well, I don't have enough time for you today. You need to come back tomorrow.
And do a separate.
And we need to have a phone consult where we have an hour to talk about it.
Yeah.
So, that can be hard, like in a pediatric clinic setting.
Yeah.
So.
Would you ever do like a PANDAS specialty clinic?
I don't know, but I don't know if that would be sustainable, to be honest with you.
Oh, really? I don't know. People pay. That's all I'm saying.
Well, I don't know that, maybe.
All right.
We'll see. But that would be something that would, you have to have enough individuals, and it's, I like some of the other stuff that I do too, so I'd have to probably give a lot of that
You do
up.
other things.
So do you think like other, because there's a lot of medical professionals that don't believe this is real. Right?
I mean, I'm a little sus, to be honest.
I know you are.
Yeah, I know.
I can tell.
Yeah.
But there's a lot of medical professionals that don't believe it's real.
Like you just got like you weren't.
I didn't believe
until,
in it until, and I was not the kind that was like knocking down doors to try to get my kid this diagnosis. Like when it was first mentioned to me, I was like, "What? What do you mean?" Like I thought we all were taught that wasn't a real thing, or it was kind of like a joke. And I had to be convinced. Once I saw lab work, and then he was put on an antibiotic, and like within 24 hours, he's a different child. I was like, okay, now I can no longer deny that this is a real thing. And then once my eyes were open to it, then I started seeing it in my patients. I was like, holy shit, this is like going on, and it's something that I've brushed off or didn't pay attention to in the past. But I feel like there's still a lot of medical professionals that don't believe it's real.
Yeah, I mean, we weren't trained, even in the hospital setting, we talked about all kind of stuff. I mean, at Texas Children's, they were on top of everything. They were at the forefront of every single research, and this was never brought up. In residency, it wasn't brought up. Again, occasionally you'd get a parent would come to you and say, my kid has this, and you would brush it off. But until I think it became more or hit home a little bit more. So, with the 2 patients that I know well, at first, I think that's when it opened my eyes, because I knew them before and how they acted and how they were. And you could see in the clinic that they were a different child. Yeah. And then you could see after they were treated, they're back to their baseline. So when you see these drastic swings, I believe that. That's when I think you can, it opens your eyes to it, and you believe it, because it is a real thing.
It is a real thing. It is a real thing. I'm not saying it's not a real thing. Especially if you put data in front of me, give me evidence for something to be true. And if you give a kid a specific antibiotic and it totally gets them back down to baseline, then that you can't deny it. And what also is frustrating is I have at least 3 to 5 probably panda-esque kids in my office who I mean, I don't know if these kids have PANDAS or not, but if an antibiotic could fix it or whatever, like why isn't there pediatrician like shouldn't this be like a screener just automatically, like all the other shit?
Again, I think it's time. I think we don't have the time.
All right.
You know, if you have 10 minutes
you. I mean, like, you know, like
just in general, they
just
don't.
big systems.
Oh, you
know
think
what I
people
mean?
who see kids? Is that what you're talking about in general, not just pediatricians?
No, well, no, I mean, no, I think because
I think for pediatricians, it's because y'all don't have time.
But can it not be like okay, when we go to the pediatrician and it's like, oh, it's let me know how your kid's doing time, and I have to click all of the sometimes never whatever like pre-check, like couldn't you like do something like that? Like before, you know what I mean?
Yeah, so that's
like
not
Oxford would
that's
do
not
that,
recommended.
not like
that's not recommended by like AAP right now. So you're talking about like developmental screenings, probably like for younger kids.
But it would I guess.
You know, so that's something that's recommended to catch things early for if you have a developmental issue.
But this could
well, so that development's been something for forever that the American Academy of Pediatrics has trained their pediatricians in. So this is something that has probably increased in prevalence and has been around for a little bit or a while if you go back to like the rheumatic fever. But it's not something that's widely recognized by the AAP yet, so it's not taught to the pediatricians. So then they don't implement it in their clinics. And
why don't they?
And it's not covered by insurance as far if they had a screener. So the screening things that you fill out, you can bill insurance and they'll pay for that. So, so if that happened, then maybe this would happen. But so to go a little bit further on that, so AAP came out with a clinical report just last month. So if you're a pediatrician and you're listening, and you look at the article, the Pediatrics, which is their main journal that they put out, they came out with a clinical report saying basically that we believe that PANDAS is real. They use the words.
Gee, finally.
They said real?
Likely real.
Oh my gosh.
And they went through what it is and how, the criteria for diagnosis. So they went far enough to write an article in their major journal and publish it. So that's a big step for them, but they did tiptoe around things like treatment. So I think and some of it, is to be politically correct. So they don't want pediatricians to go put everybody on antibiotics forever,
especially not now.
In
this climate.
So they, there was a lot of tiptoeing in the article, but it was a big first step for them to actually somewhat recognize it.
Yeah.
I mean, to put it out there, I don't think they ever would have done years ago. But I do think, with, as time goes forward, it's going to be hard for pediatricians to kind of deny some of these things because we're seeing more of it. And when you see these big swings, with treatment, and if you know your patients, I think they're going to start to see it more and more. So that's coming down the road. Probably.
I wonder if, because we've talked about how like ADHD and autism diagnoses have like shot up, like the quantity, and I wonder if it'll like equal back out. You know what I mean?
Maybe
like
some
if
of
PANDAS
those
will replace some of those
some
diagnoses,
of those kids that probably don't really
and
have
don't
autism.
need to be on stimulants or whatever.
Maybe.
And you know what I mean?
Yeah, hopefully. I mean, I hope it. Yeah, I mean, because the worldwide prevalence of autoimmune diseases is going up. Anyway,
is that because of COVID? Because we were all masked up for years, and so
I think this way predated COVID.
Yeah.
It's probably a million different things. I wrote it down somewhere.
Was that a stupid? Was that
no,
stupid?
that's not a stupid question, but this predated COVID.
Oh.
But yeah, like the
Why are
worldwide
you
prevalence
laughing?
is going up. So like most likely the prevalence of PANS and PANDAS is going to go up too because it's also an autoimmune condition.
Yeah, and I think we've seen that. I think the 1 in 200. It's probably higher than that.
Yeah.
So, and there's going to be different degrees of it too. So, some kids will have, and sometimes their first infection, it's not so bad. Like they get strep and they get, treated a few days later and they're a little clingy and their sleep's a little off. And then, 6 months later, they get another infection, and the symptoms are a whole lot more severe. So
I mean, I think the big takeaway, even though you guys don't have enough time to like dig in every single appointment you have, but for parents to know that like they can request like a phone consult, or like, I don't know, like, hey, I'm curious about PANDAS. This and this and this happened. Like, can we schedule a meeting? Is that, or no, they can't do that.
Yeah.
Yeah, they can do that.
Well, and I think like as a parent, you have to advocate for your kid. You have to push, like, go get a second opinion.
Yeah.
If someone's telling you something that you don't agree with, go get a second opinion.
I agree.
Sometimes you just have to do a lot of work as a parent to figure out what's going on,
Yeah. Yep. So, like, I tell parents this with schools and doctors, like, you're paying them. Like,
I agree.
Like, the teacher's busy. You're like, no, like you pay a lot of money for your kid to go to that doctor, to go to that school, whatever. Like they kind of work for you. So if you have an issue or a concern or a question, like email, and don't feel like guilty that you're taking up time of whoever it is.
Right.
Like your concerns are valid and you just need information.
Yeah. And I think like a parents, especially our moms, I'm just going to say, gut intuition is like a real thing. Like when you know something is wrong, you follow your gut.
I agree. Or like your gut's right.
Yeah. Yeah. Like you have this instinct, this intuition that something is wrong.
Yeah.
And like you believe that that's a real thing. That's a real thing.
That's right.
It is. But I mean, like, Rick's like, what?
I know.
I'm like, get with the program. I'm doing 85 things.
Yeah.
Get with it.
I had to like really slap this information in my husband's face, being like, this
Men
is
are
a real
terrible.
thing.
Yeah.
Not to hate on men or anything.
Yeah. It's okay.
But yeah.
Yeah. Well, this has been really informative. I feel like we need to have you back on to do like more specific targeted stuff about, you know what I mean?
Yeah.
Like, 'cause now I'm like,
Is
this
that it?
symptomology.
We can talk more.
Well, we're on a limit with time. Yeah, Keith.
No, I'm sorry.
No, because like it's the symptomology list that just like gets me going.
That's where you're feeling sus.
Yeah.
Mm-hmm. Yep. It doesn't. You're very suspicious until the kid's living in your house. Acting.
No,
That's
I know,
right.
and I get like once the antibiotic and the whatever.
Yeah.
But I just think like it's also like anxiety can look differently in boys and girls at ages and stages and different communities and cultures and like how do you know? I don't know. I just think it's
that's
really
why
hard
I
to
think
measure.
the treatment is the litmus test. Like if these things go away on freaking azithromycin, then you're like, okay, this is not ADHD.
Yes,
ADHD doesn't go away with azithromycin.
That I agree with.
You know?
If they're like, I just.
Yeah, and they also don't, like I said, don't develop the symptoms overnight.
Right.
And I didn't mention my son, so it is near and dear to me too. So my son has this diagnosis, and and I think when you see it in your own house, it's hard to deny. We weren't sure, kind of like what you were. We were in a similar boat. We didn't know what was going on with him until he was doing a school project one day, and he had some behavioral issues, a little bit off and on, and then he could care less at the time about school at that time, and he began having issues with his writing, and he couldn't not cross the lines, and he kept erasing, and he was in tears, and it took 45 minutes to do something that would take 5 minutes, and for him, a child that his personality was, he could care less. He wanted to go outside and play. And it was just, I was like, whoa, he's got PANDAS.
But that's an obvious
and all the things kind of lined up after, after kind of seeing that.
Yeah.
And I think, unless you, are close to it, I think it's hard to, I don't know, I think it's hard to believe in, or if you don't have, again, patients that you're close to, that you understand their baseline and their before and after, or the families if you're not close to them. So I think it's tough, for providers to make that diagnosis, and it's easy to.
I couldn't die.
Roll your eyes.
I'm not. I'm not.
No, I'm saying it's easy for them to roll their eyes and
but
move on to the next patient.
This is not. like we can't bill for that. Can you bill for this?
Mm-mm.
Or you don't do that?
But yeah, no.
Yeah, like that's a medical diagnosis.
Yeah.
Purely.
Mm-hmm. It should be made, yeah. Yes. Okay. Like, I don't even diagnose it. Like, if I see kids that I suspect might have it, I'm sending them to someone that can diagnose it, a pediatrician.
Okay.
Yeah.
I was just thinking.
Yeah.
Okay. All right. Keith's getting mad, so we gotta go.
Sorry, Keith.
Sorry.
We'll have you back.
For a bit.
We'll have you back. Thinking of like what I'm doing after this with my kids. Yeah, this is great though. I want to keep the conversation going.
For sure.
Okay. Thanks for coming.
Thanks for having me.
Bye.
I'll have a hat next time.
Yeah. I'll get you one. We'll get you one.
Thanks for tuning in to this episode of the Little Brain Campaign.
Please like, subscribe, and follow.
See you next time.